here as well, and Ed Margolin. So it is just past 7:30, and perhaps we should get started. So I'd like to introduce you to John Lloyd. He's our program director, and he chairs the Grand Round. So I'll hand it over to John.
Okay, good morning, everyone. We're very fortunate today to have our first visiting professor rounds of the year. So please welcome with me Dr. John Chen. As you can see, he's standing outside of his building. I guess that's the background, but it looks great. John went to University of Virginia for his undergraduate, medical, and then PhD degrees. And following that, he did his residency and neuro-ophthalmology fellowship training at the University of Iowa. He joined the Mayo Clinic in 2014, where, of course, he specializes in neuro-ophthalmology. And he also has the fortune, or perhaps misfortune, to have your role there, Amandeep, as the Associate Program Director. And let me tell you, it gets better, yes. He is also the Director of the Neuro-Ophthalmology Fellowship there and has had numerous teaching awards for his work there. He co-chairs the Upper Midwest Neuro-Ophthalmology Group and is on multiple committees for also the AAO and the North American Neuro-Ophthalmology Society as well. He has received an Achievement Award from the American Academy of Ophthalmology, and he serves as President-elect for the Minnesota Academy of Ophthalmology. He was also selected for the AAO Leadership Development Program in 2020. He has over 100 peer-reviewed papers and received numerous research grants, and his main research interests are on ophthalmic imaging, idiopathic intracranial hypertension, and of course, what we're going to talk about today, which is optic neuritis. Thank you, John.
Great, thank you so much for that kind introduction. Let me just share my screen here. Here's the code for the CME up top to the right if you need it. But I am, again, incredibly honored to be presenting here at Grand Rounds. And again, thank you so much for that kind introduction. The University of Toronto is really world-renowned, and the ophthalmology department itself is just top-notch. Just so many amazing things come out of the University of Toronto, including the neuro-ophthalmology service. So again, incredibly honored to be here. I hope everyone's staying safe in this interesting time during COVID. As we were talking about just before this started, the one good thing about COVID is the fact that this really has become a new reality where we're able to me here in Minnesota, be chatting at the University of Toronto just over Zoom with the one benefit. But I hope everyone's staying safe and that the second wave is kind of calms down sometime soon, or hopefully we get a vaccine and one day I can go there in person one day. But this morning, what I'd like to chat about is my favorite topic, which is optic neuritis. And anyone who knows me knows that this is my favorite topic. But I think it should be everyone's favorite topic because of the amazing advances we've had over the past decade or so in the identification and discovery and characterization of these new biomarkers for optic neuritis, namely aquaporin-4 antibodies for NMO and antibodies against MOG for MOG-associated disorder. This has really revolutionized the way we approach optic neuritis, because in the past, if you had a bout of optic neuritis, really the main dichotomy is, does this patient have MS or do they have idiopathic optic neuritis? But now that we have these biomarkers for aquaporin-4, for NMO and MOG, it really changes the way we see these patients because we have to identify it. Because if they're diagnosed with NMO or MOG, it not only alters the prognosis, it also changes the treatment. And so hopefully at the end of this talk, you'll appreciate the differences between these different DMI disorders and understand the importance of making the correct diagnosis. I have no financial relationships, but we'll talk about some off-label usage for chronic immunotherapies for aquaporin-4 and MOG disease. So we're going to review the differential diagnosis of optic neuritis. We're going to compare and contrast optic neuritis from multiple sclerosis, NMO, and MOG-associated disorder, and then we'll talk about treatments. So just as a brief background, optic neuritis essentially is inflammation of the optic nerve. And it's the most common cause of an acute optic neuropathy in young patients less than 50. And patients classically present with subacute monocular vision loss. 90% have pain with eye movements. And patients often describe a dyschromatopsia where things just aren't quite as as vibrant or red as they once were. 2/3 of the time, the optic nerve is normal because it's a retrobulbar optic neuritis. And that's important because there's some conditions where you can actually have more prominent disc edema, which we'll talk about. And vision typically improves. I tend to tell my patients 90% of patients get 90% of their vision back. But unfortunately, there are some patients, you can see here 3%, that end up with a pretty poor outcome. And so this is kind of your standard typical optic neuritis that you think about. And much of what we know about optic neuritis came from the landmark optic neuritis treatment trial. And here you can see the main study was published in 1992 in the New England Journal of Medicine, and essentially showed that high-dose IV methylprednisolone speeds the recovery, but does not actually change the visual outcome. And low-dose oral prednisone at 80 milligrams a day really wasn't helpful, and it potentially even increased recurrence rate, although we don't quite understand why that happens. But essentially, in the past, if you had a patient with optic neuritis, you had a choice of treating with IV steroids to speed the recovery or do nothing, because really the visual outcome was going to be the same regardless of what you do. And that's where we were at the time of the optic neuritis treatment trial. And again, the main dichotomy was, is this MS or not MS? So one of the main driving things that the optic neuritis treatment trial set out to do was to determine the risk of multiple sclerosis after optic neuritis, and it did a very good job of that. Unfortunately, the numbers are actually very easy to remember. Overall, 50% of patients after a bout of optic neuritis would develop MS within 15 years. And because optic neuritis is so common, regardless of what subspecialty you are within ophthalmology, you're going to have either a patient or a relative or a friend who has optic neuritis. And the first thing in their mind is, am I going to develop MS? And you can just say, well, 50% at 15 years. Easy number to remember. And then it's further stratified depending on the presence or absence of white matter lesions. So if there's no white matter lesions, 25% chance of MS at 15 years. If there are white matter lesions, 72% chance. And so again, very easy numbers to remember, and something that I think we all need to know as ophthalmologists. And so this is your classic MS optic neuritis patient. And this is what we think of as the typical optic neuritis. It's going to be classically young adult female. Caucasians are more affected than Black and Asians. Patients typically have mild to moderate vision loss, but patients can present with very severe vision loss from MS optic neuritis. Classically, you have good recovery. Again, 90% are going to get 90% of vision back. Only 1/3 have disc edema. And if they do have disc edema, it's typically mild. What the optic neuritis treatment showed is that patients who developed, who had a lot of disc edema at onset of the optic neuritis tended not to develop MS because it's typically some other etiology. And we'll talk about, some of these other etiologies in a little bit. And of course, they classically have the periventricular white matter lesions. You can see why these are called Dawson's fingers here, because they look like these Dawson fingers coming off the lateral ventricles there. And so that's your classic optic neuritis. I do want you to think about that as we talk about other forms. And then at the time of the optic neuritis treatment trial, in the not MS category, you had idiopathic and you had infectious inflammatory conditions. Things like sarcoid lupus, granulomatosis with polyangiitis, Lyme syphilis, TB, and zoster. These are inflammatory conditions, infectious etiologies that can affect any part of the eye. And of course, they can affect the optic nerve and cause an optic neuritis. And so you want to have those on your differential on any atypical optic neuritis. But those are rare causes of optic neuritis. At the time of the optic neuritis treatment trial, we did know about NMO, neuromyelitis optica, but we didn't know where to place it. We didn't know if it was a subtype of MS or if it was a separate entity. And we've actually known about NMO since 1894 when Devick and Galt first initially described their series. And we know that the classic symptom is severe relapsing optic neuritis, which is why we see them as ophthalmologists. And the other classic symptom is longitudinally extensive transverse myelitis. And so this is a patient that we saw with NMO optic neuritis, where they had a prior optic neuritis attack in the right eye, leaving them with count fingers vision with severe pallor, and unfortunately developed optic neuritis in the left eye with 2400 vision. This is the classic transverse myelitis that you get with NMO, and you can see why it's called longitudinally extensive, because it extends over 3 vertebral segments. This one's extending 6 segments. And that contrasts to a classic MS transverse myelitis, where you've got a much smaller lesion. You know, with this much signal abnormality in the spinal cord, you can see why patients with NMO often have much more serious disease. They're often, you know, wheelchair bound during the first attack. Or can be. And again, it's because of this extensive demyeling process that happens here in the spinal cord compared to MS. But again, there was a lot of debate whether NMO was a distinct entity. And, you know, this is just 10 years ago, there were people arguing it's a variant of MS, and then other equally good experts saying it's not a multiple sclerosis variant. And these arguments were going back and forth. And ultimately, the answer came from the laboratory. In 2004, the antibody for NMO, which is an antibody against aquaporin-4, was discovered. And over, you know, about 3 to about 5 years after discovery, it became recognized that this aquaporin-4 antibody was both a marker and a pathogenic cause of NMO. And it firmly cemented NMO as a distinct entity from MS. Aquaporin-4 are water channel protein. It's a water channel protein in the astroglial foot processes, and it's expressed in the brain, the spinal cord, and the optic nerves, which is why this NMO tends to affect these areas of the CNS. When the aquaporin-4 antibody binds to aquaporin-4, it causes complement activation and astrocytic injury, and then secondary demyelination. And so the pathophysiology is much different from multiple sclerosis. The aquaporin-4 antibody is 76% sensitive, but has an amazing specificity, 99.8% specific for NMO. And interesting, the serum is actually more sensitive than the CSF. And the sensitivity looks like it's got a lower sensitivity, but it's actually because currently the NMO spectrum disorder diagnostic criteria has other potential diseases in there. I think the aquaporin-4 antibody is very sensitive and specific for the true NMO disease that we know. The diagnostic criteria in 2006 were pretty simple. It was optic neuritis, transverse myelitis, and you had to have at least 2 of the following: a long transverse myelitis attack, an MRI non-diagnostic for MS, and a positive aquaporin-4 antibody. But now that we've got a specific antibody for NMO, the diagnostic, the way it can present expands because we have a specific marker. And so the most recent diagnostic criteria, where it was published in 2015, and you can see here it's much more complicated now because the spectrum has expanded. I'm obviously not going to have you read this, but I'm going to boil down the core clinical characteristics. The most common is still optic neuritis and transverse myelitis. But the third most common is actually area postrema syndrome, where patients get a lesion to the medulla in the area postrema region, and they can present with refractory hiccups or vomiting. This was actually just published in the New York Times Magazine, which is a lay press kind of journal. So even the public is hearing about this disease. This was about a young, previously healthy 40-year-old woman who had terrible heartburn and vomiting. She went to the ER and had a GI workup, $1 million GI workup, and no one could figure out why she had nausea, vomiting. And then all of a sudden it resolved over 3 months and she was back to normal. And then it was just called idiopathic nausea and vomiting. We didn't know, again, $1 million GI workup. But then a year later, she developed vomiting again, but this time she had double vision. And that led to an MRI, and this was NMO. And so this is important because this could be potentially the presenting symptom of NMO. So we not only need to know this as ophthalmologists and neurologists, but even ER doctors, GI doctors need to know about this potential condition. And it was interesting that this was published in the lay press. So even patients are starting to understand this condition a little bit more. And so area postrema syndrome occurs in about 10 to 20% of patients with NMO. And the other core clinical characteristics that can occur Less frequently than those three are acute brainstem syndrome. You can even have symptomatic narcolepsy and symptomatic cerebral syndrome. The diagnosis of NMO spectrum disorder is made by one of these core clinical characteristics and a positive aquaportin 4 antibody. And you can actually make a diagnosis of NMO spectrum disorder without the aquaportin 4 antibody, but you need to have two core clinical characteristics, and one of them has to be one of these three most common ones. NMO, we're starting to understand it more now that we've got this very good biomarker for it. The prevalence really ranges a lot, between 0.5 to 10 per 100,000. And that really depends on the ethnicity, because in Caucasians, NMO only accounts for 1 to 3% of demyelinating disease, where in Asia, it's 20 to 48%. In our group at the Mayo Clinic did an incidence study comparing the incidence in Rochester, Minnesota, which is predominantly Caucasian, to Martinique, which is 90% Afro-Caribbean. And you can see there was a 10-fold increase in the incidence in the Afro-Caribbean population compared to our Caucasians in Minnesota. It's 3 to 7 times more common in women. So it's actually even more female predominant than MS, which is about 2 to 3 more common in women. And the median age is 39, which is about a decade older than MS. And so comparing and contrasting the classic MS to NMO, with NMO, again, it's going to be slightly older patient, Black and Asians more than Caucasians. The reason why we care about NMO as ophthalmologists is the optic neuritis, where patients have severe vision loss at onset and unfortunately poor recovery, with up to 50% of patients developing a vision of 2200 or worse. And that's why we care about NMO. Disc edema is less than a third. It can cause optic chiasm lesions. And so if you have, and that's pretty rare in MS. So if you have an isolated optic chiasm lesion, you want to think about NMO. Of course, the long transverse myelitis, the area postrema syndrome. And what's scary about this disease is prior reports suggest a mortality rate of 6 to 32%. Fortunately, now with better recognition and better treatment, I'm sure the mortality rates are 6% or less. But this can be a fatal disease if left untreated. Because these attacks are so severe and we know the recovery is poor, it actually alters treatment, which is why, again, we have to recognize this process. We treat with IV corticosteroids and plasma exchange because we know the natural history is poor recovery. So that's how it differs from MS, where again, with MS, you can treat with IV steroids to speed and recovery, but it doesn't change ultimate outcome. Here, we're treating with IV steroids, plasma exchange, trying to get as much recovery as possible. The other large differentiating factor between MS and NMO is that with NMO, all patients require long-term immunotherapy, but the treatments are different. For NMO, rituximab is classically the first line. Some other medications that were previously used are azathioprine and mycophenolate. But if you're going to take one thing from this talk, it's that MS medications can actually potentially increase the relapse rate of NMO. It certainly doesn't work, and it can potentially increase the relapse rate of NMO. And that's in a disease that essentially we know has a mortality rate as high as 32% if left untreated. And so we have to be able to correctly identify patients with optic neuritis as having NMO, because if we misdiagnose them with MS and treat them with a standard MS medication, it could potentially worsen things in a disease that could be potentially fatal. It's been an exciting time to be a neuro-ophthalmologist because there's been these huge advances in NMO understanding over the past year. And the American Academy of Neurology actually called 2019 the year of NMO. And that's because they had 3 different drug trials that all showed significant efficacy in reducing relapses for NMO. And this is just amazing. There are 3 trials, all 3 were successful. You compare this to Alzheimer's disease research, where I think just this past year we probably had 15 clinical trials and all of them failed. Here we were 3 for 3 for this condition. The first study was the PREVENT study, which looked at eculizumab, which is a complement inhibitor. And this was really an exciting study because we knew that aquaportin 4 binds to antibodies bind to Aquaporin-4, and it actually activates complement. So this used the pathophysiology of NMO, knowing that it acts through complement, and it found that eculizumab did reduce attacks, and it actually reduced it by 94% compared to placebo. And it became the first FDA-approved medication for NMO spectrum disorder. The next study was the NMO momentum study, enabolizumab, which is a CD19 inhibitor, also caused a significant reduction in attacks. And the SACRA-STAR study looked at satralizumab, an IL-6 inhibitor, also showed a significant reduction in attacks. And these are actually now are all FDA approved, enabolizumab and satralizumab, just this past month. And so we now have these 3 medications in our back pocket in case patients start relapsing through some of the more traditional medications like rituximab. And so again, it's an exciting year for NMO and a lot of breakthroughs in the management and treatment of this condition. So going back to our diagram of optic neuritis, we now know that NMO is a separate entity from MS. And we've got a very good biomarker, Aquaporin-4 antibodies. But what's interesting is only 75% of patients are positive for Aquaporin-4, which means there has to be some other conditions that we don't know about at the time of the diagnostic criteria. And the question is, what are some of these antibodies? Well, over the past few years, we've recognized that antibodies against MOG can actually explain at least a third of seronegative NMO spectrum disorder. It also can explain some atypical cases of MS and some idiopathic optic neuritis, especially the recurrent ones. And so now, again, MOG antibodies it's much newer, probably much less recognized, but it's starting to be understood a little bit more. I thought I'd start off with a classic case of MOG optic neuritis, again, because it's a little bit newer than NMO. This is a 48-year-old male who presented with blurred vision and pain in both eyes, and he came to our emergency room because of this decreased vision. And my ophthalmology resident saw this patient in the clinic, and he said, "Dr. Chen, I've got a patient with grade 3 papilledema. I think we should get an MRI, MRV, spinal tap. Leading diagnosis is idiopathic intracranial hypertension or some secondary cause of intracranial pressure." However, this patient was count fingers in both eyes. And yes, there's a lot of disc edema, but this would be a grade 3 disc edema. And typically, yes, you can have fulminant IIH or fulminant venous sinus thrombosis causing count fingers vision, but those patients tend to present with grade 5 papilledema. And so yes, this was disc edema, but it wasn't that amount of disc edema you'd expect to cause severe vision loss. And if you hear about his pain, he had pain in both eyes, but it was classic pain with eye movements. And so this patient, in my mind, wasn't raised intracranial pressure wasn't high on my differential for him. Really, it was optic neuritis, especially with that classic pain with eye movements. And so we got an MRI of the orbits, and it confirmed bilateral optic neuritis. And you can see this enhancement of the optic nerve extends down the entire optic nerve in both eyes. And what's interesting is the enhancement actually extends to the sheath and the peribulbar fat. And that's a very interesting radiologic finding, which we'll talk about, but it's classic for MOG. So if you look at our differential diagnosis of optic neuritis, we've talked about MS, we talked about Aquaporin-4, but I would argue with this MRI and this fundus appearance, I would not think that this would be MS or NMO. Highest now, obviously, now that we know MOG-associated disorder, MOG would be highest in my differential. But if you didn't know about MOG, certainly these other things can do a similar presentation, including sarcoid, some of these infectious etiologies, infiltration, and idiopathic, some other antibody we don't know. But I would say not MS or Aquaporin-4 with this clinical presentation. So at the time, this patient was actually diagnosed before we were checking MOG antibodies on a regular basis. So they're diagnosed with an atypical optic neuritis because it's rare to have bilateral optic neuritis in adults. And there's that significant disc edema. We talked about how optic neuritis can have disc edema in a third of patients, but it's typically mild. And this was obviously significant with some peripapillary hemorrhages. So initial workup was negative. The CSF showed no oligoclonal bands. The Aquaporin-4 antibody was negative, and the infectious inflammatory workup was negative. So the patient was treated with IV methylprednisolone for 5 days and had almost immediate recovery of vision. And this was interesting because we know that when you treat with IV steroids, we typically think that it speeds recovery. But we're talking about, patients get vision back in 3 weeks instead of 6 weeks without treatment. But this patient was back to 20/20 within 2 or 3 days of the IV steroid. So before they even finished the 5th day, they're 20/20. And that's faster than you expect for MS optic neuritis. So again, another atypical feature of this optic neuritis. But unfortunately, when the patient tapered off the steroids, they had a relapse of optic neuritis that required steroids. And then every time they tapered off the prednisone, they had another relapse. And so clinically, this was chronic relapsing inflammatory optic neuropathy, or CRION. It's a clinical diagnosis that we've known about, but in the past, they were all thought to be idiopathic. Because in these cases, the optic neuritis is steroid responsive, but to make a diagnosis of CRION, they have to be steroid dependent. And ultimately, this patient was stabilized on azathioprine 100 milligrams twice a day. And not surprisingly, the patient was positive for MOG antibodies at 1 to 100, now that we know how MOG can present. So what does MOG stand for? It stands for myelin oligodendrocyte glycoprotein. It's a transmembrane protein found on the surface of oligodendrocytes in myelin. And antibodies against MOG are very specific for a distinct demyelinating disease, which we now call MOG-associated disorder. And at least in the US, it's been commercially available since October of 2017. So really, we've had this, at least in the US, this assay for only 3 years. And so obviously our understanding of this disease process is still growing. The demographics, really it can affect any age. We've seen them as young as 1, as old as 82. The median age is 33. It probably makes up over 20% of demyelinating attacks in children and about 5% of demyelinating attacks in adults. Unlike NMO and MS, the female to male ratio is actually 1 to 1, and it's probably 2 times as common as aquaporin 4 for optic neuritis, at least in the Caucasian population. So I just thought I'd step through different ways that MOG-associated disorder can present. The most common is optic neuritis, which is why we need to know about this condition as ophthalmologists. And the features of optic neuritis that would make you want to think about MOG is 50% are bilateral, 50% are recurrent, and some are steroid dependent and therefore, previously would have been called CRION. And MOG antibodies probably explain about 50% of previously idiopathic CRION. So anytime you have a patient with steroid dependent optic neuritis, you want to think about MOG disease. The disc edema is an interesting finding. It's present in probably about 80% of optic neuritis with MOG, compared to less than a third for MS and NMO. And sometimes it can be severe. In about 40 to 50% of a MOG optic neuritis, you can have moderate disc edema, which is something you almost never see with MS or NMO. You can see this patient even had some peripapular hemorrhages. So sometimes these patients can get incorrectly diagnosed with idiopathic intracranial hypertension. They've been incorrectly diagnosed with NAION just because of that amount of disc edema. So you just want to think about this condition because it can affect any age group. The MRI is certainly a clue to it. With MOG optic neuritis, they tend to have optic nerve sheath enhancement, which you can see here. And probably the most specific finding you get with MOG, at least in terms of the MRI, is this perineural enhancement, where it not only involves the sheath, but it involves the peribulbar fat. So if you see it extending into the peribulbar fat region, that's usually going to be MOG. We almost never see this amount of enhancement for MS or NMO. And then with MOG, oftentimes you have bilateral enhancement or a long segment enhancement. You can see our patient here with this segment enhancement involving the entire orbital portion of the optic nerve, and it extended all the way back to the chiasm. You can see that longitudinally extensive lesion with NMO as well, but definitely you don't typically see that with MS. So if you see this long lesion, or if it's bilateral, you want to think about NMO or MS. And if you see that peribulbar fat, this perineural enhancement, you want to think about MOG. And that's in about 50% of patients. MOG optic neuritis tends to have very severe vision loss at onset, but fortunately the recovery is much better than NMO. This was a study looking at recurrent optic neuritis, comparing it between MS, MOG, and aquaporin 4. And what it's showing here is the chance of retaining good vision. And in pink and black are MS and MOG. And despite MOG having multiple recurrent bouts of optic neuritis, the majority of patients retained usable good vision. In blue, we've got our aquaporin 4 NMO, and you can see with recurrent bouts of optic neuritis, the chance of retaining good vision becomes lower and lower over time. And so fortunately, although patients tend to present with very severe vision loss with MOG, oftentimes count fingers vision, light perception vision, the recovery is much better. Where only 6 to 10% of patients end up with 22 and worse compared to 50% for NMO. So fortunately, outcomes are better despite the severe vision loss. And so that's really how optic neuritis is going to present for MOG. And anytime you have any of these
John,
characteristics—
before you leave that slide,
yes.
What is DM?
DM.
There was another category.
Oh, I'm sorry, DN here. I should have talked about that. So that's double negative. So these are patients, essentially we call them idiopathic optic neuritis at this point. And essentially these are patients with recurrent optic neuritis. They're not MS, they're not MOG, they're not aquaporin 4. They have some other antibody floating around. And what's interesting is the outcome was actually in between MOG and aquaporin 4. So this mix of antibodies, there's probably some other 2 antibodies, 3 antibodies that have a moderate phenotype that we don't know about. So obviously we're still in the laboratories trying to find these other biomarkers, but there's definitely other ones floating around out there. So on the right, as ophthalmologists, this is what we're going to need to know about MOG optic neuritis. And this is the way it's going to present. But MOG can affect other parts of the brain as well. It can cause transverse myelitis, and this is a patient with transverse myelitis extending 4 to 5 vertebral segments. So it's a long segment of transverse myelitis. But what's interesting is that it often affects the central gray. And here's an axial cut showing what our group called the H sign. But if you're a sports fan, you could say, well, maybe this is the Under Armour sign. And if you're a sci-fi fan, maybe you could call it the TIE Fighter sign. But regardless, if you see this central gray signal abnormality in a transverse myelitis, you want to think, maybe this is going to be MOG-associated disorder. And when you have optic neuritis plus transverse myelitis, you actually meet the 2015 diagnostic criteria for NMO spectrum disorder. And it actually MOG explains about 1/3 of aquaporin 4 negative NMO spectrum disorder. And obviously we need new diagnostic criteria to exclude MOG from the NMOSD, and that will obviously improve the sensitivity of the aquaporin 4 antibody, just because we've got these MOGs mixed in there. And there's some other diseases mixed in there as well that we don't know yet. The other most common way it can present is ADEM, acute demyelinating encephalomyelitis. And this tends to occur in children. At least 50% of ADEM attacks that we thought were idiopathic in the past were actually caused by MOG. And it also can cause ADEM in adults as well. I remember before we had this antibody, these patients used to keep me up at night, because these patients would come in with significant confusion, encephalopathy. They'd have bilateral optic neuritis. So these kiddos would be blind, they'd be confused, they'd be encephalopathic, and we didn't know what was going on. We assumed it was an inflammatory process, but infectious and neoplasm were on the differential diagnosis. And some of these patients even got a brain biopsy. Sometimes we would just treat empirically with steroids and hope for the best, and these patients miraculously got better. And in retrospect, all of those patients that I saw that kept me up at night trying to decide, do I treat with steroids or not? Those were patients with MOG, because again, when you've got ADEM, especially in childhood, 50% are going to be caused by MOG. And if you add in that bilateral optic neuritis with ADEM, it's going to be MOG. So it's really nice now that we've got a biomarker to help confirm our suspicion in these children. So these are the diagnostic criteria that our group proposed. And essentially, the main one is a positive serum MOG antibody. It has to be with a cell-based assay. And then one of these main clinical phenotypes, the ATOM, the optic neuritis, transverse myelitis, and then there's some other brain and brainstem syndromes that can occur as well. And of course, we have to exclude alternative diagnoses. It really is its own entity. It's distinct from MS. It's very rare to have a classic MS to be positive for MOG antibodies. And the treatments with MS medications are ineffective. It's also distinct from NMO spectrum disorder. There's almost no patients that are positive for MOG and aquaporin-4. We looked at 1,000 patients or 10,000 patients that were tested for MOG and aquaporin-4, and only 0.06% of them were positive for both. And if you took only the 1,000 patients that were either positive for MOG or aquaporin-4, only 0.6% were positive for both. If they did have dual positivity, they typically had a very high titer aquaporin-4 and a much lower titer MOG, and they followed the aquaporin-4 NMO phenotype. So likely the MOG antibody, what we suspect is just these patients who have a tendency toward autoimmune disease with aquaporin-4 NMO, where patients can also have coinciding lupus and other autoimmune features. They've got a low titer MOG, but really if they're positive for both, the aquaporin-4 is going to be higher, and they're going to follow that NMO phenotype, unfortunately. The pathology is different as well. Again, we didn't have this biomarker in the past, so a lot of these patients ended up getting biopsies. And with aquaporin-4, you see astrocyte destruction and secondary demyelination, where in MOG, you have type 2, pattern 2 demyelination in terms of its pattern. The outcomes for MOG are much better than NMO. And so really, ultimately, MOG has a different prognosis and a different treatment. So it really is its own distinct entity. Groups are working on formal international diagnostic criteria for MOG. So the treatment for MOG is, again, slightly different. It's going to be IV steroids for 3 to 5 days. But because some of these patients are going to be steroid dependent, we tend to do a prednisone taper over 1 to 2 months because we're trying to prevent that relapse that can happen, like I showed in our index case. And so we typically do a prednisone taper over 1 to 2 months. If they have another relapse, we might go 3 to 6 months, a longer, slower prednisone taper. We only consider plasma exchange or IVIG if it's severe vision loss and there's no recovery after 1 to 2 weeks, because usually patients recover to IV steroids, so we're not jumping right to plasma exchange. Unlike NMO, where we know that the outcomes are poor, they need everything they can do to get recovery. For MOG, patients tend to recover. So again, we reserve plasma exchange or IVIG only if the vision loss is severe and there's no recovery. The chronic immunotherapy is actually also very different. So with NMO, every patient needs to be on chronic immunotherapy. That's where this is a large dichotomy. Because only 50 to 60% of patients are going to relapse who have MOG, and the recovery is much better after attacks, we do not recommend treatment for a single attack, especially if they have good recovery. If they have a single attack and severe deficits, obviously we would consider chronic immunotherapy. But if you've got a single attack and the majority of patients have excellent recovery, we just leave them be without treatment and just observe. The long-term immunotherapy really is only required for relapsing disease, which is in about 50 to 60% of patients. And then if you are going to treat, the big question is what treatment are you going to do if they do have relapsing disease? So we did a multi-center retrospective review of 69 MOG patients who were treated with immunotherapy for over 6 months. And a couple of things I wanted to point out here is that we compared the pre-treatment annualized relapse rate. So that's how severe disease was before treatment. And then the relapse rate on treatment. And the higher, and this is the number of relapses per year. And so the higher the number, the worse. And the first disease treatment I wanted to show is the MS disease modifying agents. And you could see that the MS medications had no effect on the relapse rate. So it really was not effective for MOG-associated disorder, which other studies have shown as well. It didn't seem to increase the relapse rate. So unlike NMO, where MS medications can worsen disease, for here it seemed to just be ineffective. Then we've got our traditional medications that are used for NMO, which are mycophenolate, azathioprine, and rituximab. You can see here that all three medications led to a reduction in relapse rates compared to prior to treatment, but certainly a lot of patients still relapse through these medications, so they're not perfect. What's interesting is that monthly IVIG led to a significant reduction in relapses compared to these other ones. You can see pre-treatment, the annualized relapse was actually the highest among these other medications, and after treatment, we had a very significant reduction in relapses. Unfortunately, we only have 10 patients, and so this is certainly something that needs to be clarified and confirmed in future studies. But it does suggest that monthly IVIG may be an effective treatment. And right before COVID, we had a MOG-NMO meeting in Europe right before things shut down. And a lot of the Europeans are also finding IVIG to be very effective for MOG. And so currently we're putting it together a large multi-center international group to kind of look at all these cases. But it does seem like there might be a lot of promise for IVIG. Because of the cost of IVIG, the requirement for monthly treatments, our first line treatment for patients with relapsing disease is still typically rituximab or azathioprine, often with a low dose maintenance oral prednisone. But at least if patients have severe relapsing disease that breaks through these medications, we've got monthly IVIG in our back pocket for something that we can switch them to. I think one question that people often have is, yes, we've got these biomarkers now, but am I ever going to see this in my clinic? How common are these diseases? So in the past, one of the most commonly cited studies was one done at the Mayo Clinic back in 1985. And it found that 52% of optic neuritis were MS and 48% were idiopathic. And this was obviously done in 1985, so it was before the knowledge of aquaporin 4 and MOG. So given these new biomarkers, we did an updated incidence study from 2000 to 2018. We actually drew blood in all these patients in Olmsted County. And we found that 57% were from MS, similar to the prior study. 31% were idiopathic, so that idiopathic group is dropping. And 3% were NMO, 5% were MOG. And this is a population-based study showing that essentially 8% of optic neuritis is going to be NMO or MOG. This study utilizes something called the Rochester Epidemiology Project, where we're only looking at patients within Olmsted County to get that population-based percentage. Because if you were to look at all the patients within my neuro-ophthalmology clinic with optic neuritis, you'd think that 50% are MOG, 30% are NMO, and 20% are MS. You get this huge bias toward referral bias, obviously to more severe or atypical disease. But this study, the Rochester Epidemiology Project, allows us to see what's in our backyard at a population-based level. And so 8 to maybe 10% of your optic neuritis is going to be one of these diseases. So we do have to think about it. Every 10 patients or so is going to have one of these atypical cases. So next big question, when should I test for aquaporin 4 and MOG? I'd say you can consider testing for this for any optic neuritis unless it's classic MS. If it's classic MS, you're not going to want to test for them, especially MOG, because you're going to get some false positives mixed in there and really isn't going to change management. If you've got a classic MS with periventricular white matter lesions, it's probably going to be MS. If it looks like a duck, quacks like a duck, it's probably going to be a duck. But we think we do need to test these for any atypical optic neuritis. And we've talked about some of these atypical features, which is the severe vision loss, bilateral recurrent optic neuritis, prominent disc edema, which would make you think about MOG, long segment enhancement on MRI, which could be MOG or aquaporin 4, enhancement of the optic nerve sheath or chiasm. Those are all the reasons to check for MOG and aquaporin 4. And then if you have CNS disease that's atypical for MS, like ADEM long transverse myelitis, aerial post-streamus syndrome, or again, anything atypical for MS, you're going to want to think about aquaporin 4 and MOG. Again, because it changes management. How to test? You're going to want to test the serum. The serum actually has higher sensitivity than the CSF, especially for aquaporin 4. There are some rare cases of possible MOG being positive in the CSF that was negative in the serum, but those are some preliminary studies. But for the most part, the serum is much more sensitive for both. And it's important that these should be cell-based assays. These have much higher sensitivity and specificity than ELISA or any of the other assays out there. And so, again, want to have to check serum, and it has to be a cell-based assay to get your best yield. And the specificity, again, is amazing for aquaporin 4. It's 99.8% specific. For MOG, the specificity is about 98%, which is excellent. But obviously, if you test a bunch of patients with low pretest probability, like a bunch of patients with MS-type phenotypes, you're going to end up getting some false positives. So again, excellent aquaporin 4 antibody, very good MOG antibody, but still want to test them in the appropriate clinical scenario. And then for the MOG assay, it's the titer amount matters in terms of higher specificity. So the lowest positive one, at least we can get for our MOG assay at the Mayo Clinic, is 1 to 20. And then it goes up to 1 to 100, 1 to 1,000. 1 to 100 or higher has a higher specificity, lower false positives there. So that's where the titer can help. So just finally, wanted to compare and contrast these various causes of optic neuritis, now adding in MOG. So MOG, again, can be any age, any sex, explains a large percentage of childhood optic neuritis. So far, we don't think there's a racial predilection that we found yet. With MOG optic neuritis, you've got severe vision loss at onset, but fortunately good recovery. And so ultimately the outcomes are better. The disc appearance, 80% are going to have disc edema, 50% are going to be bilateral. And that perineural enhancement, which is there in 50% of patients, is going to be a large tip-off that this is going to be MOG-associated disorder. In terms of lesions outside, in terms of the spinal cord, both MOG and NMO are going to cause the long transverse myelitis. But of course, the MOG is going to affect that central gray and cause that H sign. And then the classic brain lesions for MS would be periventricular white matter lesions, aerial posterior for NMO, and ATEM for MOG. And so this is just a nice way, an easy way to kind of compare and contrast the way these are going to present. And again, what's important is it changes treatment, which I think we've talked about. So going back to this schematic where we got to NMO, we got to MOG, there's a lot of these arrows going around, but really they are their own distinct entity. When you have a patient with optic neuritis, it may be MOG, it may be NMO, but they're not going to be both. They're distinct entities. And, you know, we still have a lot of idiopathic optic neuritis there. And I suspect there's some atypical variants of MS that are also going to be caused by some unknown antibodies that are yet to be discovered. So in summary, optic neuritis has multiple causes. We want to differentiate MS, aquaporin 4, and NMO. Aquaporin 4 and MOG antibodies have to be tested for any atypical optic neuritis because ultimately it changes treatment and prognosis. Just want to thank a lot of collaborators which put these studies together. At the Mayo Clinic, especially Owen Flanagan, Tarek Bhatti, and Sean Piddock were instrumental to all this work. And then we've got phenomenal collaborators outside Mayo Clinic as well. This whole list of neuro-ophthalmologists that have contributed patients and thoughts and ideas toward this work. And again, I want to thank the University of Toronto for having me at Grand Rounds. It's really been an honor, and I'd love to take any questions anyone might have.
John, just wanted to thank you.
Thank you very much, John. That was fabulous. There was a question that rolled in from the audience, which I'll lead off on from Alexander Pearson. Is there an explanation for why MS medications can increase relapse or are harmful in NMO?
That's an excellent question. We don't know exactly why that is. there's no doubt every study shows that MS medications do not work, the traditional ones, but we're not sure why it would worsen it. These were mostly just retrospective studies because we can't prospectively put patients on it. So we don't really know why it worsens it, but clearly doesn't improve it, and studies have suggested it worsens it. That's for the traditional medications. The newer ones like ocrelizumab, they probably are actually effective, or at least somewhat effective for some of these other conditions. So some of these patients where we can't figure out, is this possibly NMO, is this possibly MS? We may put them on a medication like rituximab or ocrelizumab, one that would cover both, kind of hedge our bets, but we would never put them on a traditional medication. Could it potentially worsen things? Or at least definitely doesn't help.
John, just wanted to thank you for the excellent talk. I wanted to ask you, can you give us a little bit of a preview, glimpse of what is your lab working on right now in terms of newer antibodies? Because I know you are looking into some newer antibodies, so maybe you can share some of that with us.
No, absolutely. I think that's going to be the future is newer antibodies. We've recently characterized antibodies against CRIM5 and GFAP. I know the neuro-ophthalmologists are now aware of that. It doesn't cause the classic optic neuritis. It's usually more of this disc edema with a little bit of optic neuropathy. It doesn't cause the retrobulbar enhancement, but that's something that's been published over the past couple of years. In terms of even newer antibodies, really still just working. We've got pig models in the lab that we're constantly screening for new antibody, and we have a very large biorepository where we're collecting all these cases of idiopathic recurrent optic neuritis. No great hits yet. We've sent off for phage display, trying to find some hits. We thought we had one, but then when we went back, it ended up not being a specific marker. So we're still working, but I think what it takes is a lot of serum from a lot of idiopathic recurrent optic neuritis, and there has to be other biomarkers because these are obviously not idiopathic when you've got 5 bouts of optic neuritis.
And John, can you tell us just a little bit for the uninitiated, how does this work done in the basic lab, looking for the antibodies? What do you do like on a basic level? How do you search for a new antibody?
Yeah, so we often use immunohistochemistry as a screening tool. So essentially we've got our optic nerve, and we look for staining patterns that are maybe specific for an actual disease. And then once we find potential ones, then it goes to Western blot, then mass spec. So we just kind of go from there. And then, there's some newer techniques like phage display. So just a bunch of different ways. Traditionally, we've been looking for tissue pattern staining. That's been our traditional way. We found aquaporin 4. That's the way we found a lot of these paraneoplastic antibodies like CRIM5 and these other ones. But yeah, so screening, usually looking for staining patterns is our initial step. But there's newer techniques out there that we're trying to tap into.
So a lot of sera from idiopathic.
Yes, yeah, absolutely. The more, the merrier.
Okay.
Sorry, hi, John. I just want to ask a question along that course. How are you handling these double negative patients? So we've been getting recently these patients with very severe vision loss, longitudinal enhancement, optic nerve enhancement, and then their MRI brain is normal. We've tested MOG and aquaporin for multiple labs with cell-based assays. They're negative. This vision loss is so severe, we treat them usually with high-dose steroids and plasmapheresis. Right. Some recover, some incomplete recovery. Mm-hmm. And we're always in this debate, should we start an immunosuppressive medication, for how long? So I just wanted to know your approach to these patients.
Absolutely, that's an excellent question. I think, if it's recurrent, if it's just like you said, and it's recurrent attacks, we would put them on immunosuppression. We'd probably start off with a medication like rituximab, one that tends to work for a lot of these demyelinating conditions. If it's a single attack that was severe with incomplete recovery, that's a tougher debate, tougher question, because that might be the one attack and they may never have another attack again. I think that comes down to how severe the vision loss is, and a patient physician discussion, because there's a little more gray zone there. So I guess easy answer, severe disease, recurrent, you're just going to treat them. I'd probably put them into this, even though they don't meet the criteria of NMO spectrum disorder, you know, you'd have that mindset in terms of, you know, they need the treatment. A little bit, again, harder if you've got the single attack. Let's say they're still 20/20 in one eye and the other eye's bad. It's a harder call there.
And then here in Ontario, we have a hard time getting rituximab, and the government will only cover this if people have failed multiple other medications. So just wondering, if for these MOG patients that are recurrent or have incomplete recovery, what's your go-to medication first line?
Probably azathioprine. Yeah, azathioprine. You know, actually, some recent studies suggest that for MOG, rituximab actually is not that effective. So, again, it probably does cause some reduction in attacks. It's not perfect by any means. Neither is mycophenolate, neither is azathioprine. But I think, you know, we often will use azathioprine. We think it does cause a reduction in attacks, but again, not perfect. If they continue breaking through that, that's when we switch over to monthly IVIG, but that's hard in terms of insurance purposes. It's monthly treatments and it's pretty costly. So we still try azathioprine first typically.
Okay, thanks.
Just as we're having the discussion, could you do me a favor and just put up your first slide again that's got the QR code so that our late attendees can scan it to get their CME credit? And then I had a question, and also maybe Jonathan, if you're the host now, there's a couple of people raising their hands in the audience. Maybe you can call on them. But my question is just, since these antibodies do change your treatment paradigm, especially like NMO, where you may want to institute plasmapheresis very early, how long does it take to get these tests done? And maybe the answer is different in the Mayo Clinic than it is in Toronto.
No, it's tough. It takes, you know, outside it'd probably take 2 weeks. Within here, it'd take maybe a week. You know, we run these tests, you know, once a week or twice a week. So if you just miss that, it's gonna be a full week, maybe 2 weeks before you get the antibody back. So you're right. That's the big debate, is how do you treat these patients now with acute optic neuritis, first attack, when some of these are going to be NMO, but the vast majority are going to be not NMO and they're going to be fine. It's tough. I think right now what we do is we tend to still treat with IV steroids if they've got acute severe vision loss. If they've got bad vision loss, I don't give them the option of observation. We're going to treat them with IV steroids right off the bat. And if it's severe vision loss and they have no recovery after 1 to 2 weeks, then we add on plasma exchange, because, you know, waiting for these antibodies for that first attack could be an issue. And it's tough because we're going to overtreat some patients. You know, some of these patients who are light perception or our optic neuritis treatment trial showed that a lot of them are going to recover anyways, but, you know, some of them aren't. So yeah, if it's severe vision loss, no recovery after IV steroids, we might add on even before the antibodies are back if they don't have recovery in that 7 to 10 days.
Jonathan, there was a couple people raised hands in the audience, Myrna Lichter, Jasmine. I don't know if you're able to let them ask their question.
Sure, I allowed. Myrna, do you want to ask a question?
Yeah, are any of those new NMO drugs that we're using effective in the idiopathic cases?
For the idiopathic cases, that's a good question. So the eculizumab study had no seronegative NMO. So we don't know how that's going to work for our idiopathic cases. For the satralizumab study, there was a small percentage of patients that were aquaporin-4 antibody negative, and it was actually not very effective. And I'm sure some of those are going to be MOG, so it's harder to know. But yeah, for the satralizumab, didn't seem to be that effective. They were much more effective for the aquaporin-4 positive one. So I would say, and then the enobolizumab was a mixed bag, possibly effective for the idiopathic ones. And again, some of them are going to be MOG. So bottom line is, eculizumab, unfortunately, we have almost no data on. Satralizumab doesn't seem to help. And enobolizumab, probably a mixed bag. I suspect it's going to be similar to rituximab in that it probably does cause a reduction, but not perfect.
Thank you.
John, we have approval for eculizumab, but the problem in Ontario is that in order to qualify, you have to fail multiple treatments. So once these patients are NOP in both eyes and in a wheelchair, then we can get the medication, which is unfortunate. So hopefully we'll have improvements with that.
Yeah, and actually, even though we have approval for eculizumab here in the States, our first line is still typically not eculizumab because it requires treatment every 2 weeks. And then two, it's by far the most expensive medication. But so we still typically start with rituximab, but if they have severe relapsing disease, eculizumab out of all the trials did seem to show the largest reduction. I mean, it was a 94% reduction in relapses. So we will reach out to that in our back pocket, but we don't typically start with it. Again, every provider is different though.
While we're waiting, I just want to ask you a quick question. Just thinking about why do people kind of randomly get MOG and then never get it again? And then there were all these papers recently about possibly associated with COVID and people saying that many patients with MOG have had a preceding infection. Has that been your?
That's a very good question. So about a third of patients with MOG do have a preceding viral type illness. And so the thought is that you have this virus and your immune system's fighting it off, and then you end up creating these antibodies with MOG as a biomarker of this disease. And then you have the optic neuritis and whatever demyelinating attack. And so with patients after COVID getting MOG, it's probably not specific to the COVID itself. Otherwise, we'd probably have way more MOG cases, but it's probably just one more viral illness that can trigger it. Then in terms of recurrence or not, there's been a lot of debate, whether, persistent antibody titers matters or not. And for the most part, it's tough. 2/3 of patients are going to stay MOG positive, but just because you're persistently MOG positive doesn't mean you're going to relapse. But a third of patients become seronegative, and if you become seronegative, there is probably a lower chance of relapse. So we do tend to recheck MOG in 6 to 12 months after an attack. If they're still positive, we say, well, we just shrug our shoulders and say, well, that's 2/3 of the population. But if they do become seronegative, we can say, well, chances are it's less likely that it'll come back. But we don't know why it can relapse later. Now, we've had patients who relapsed 15 years after their initial attack. They had ATEM as a 6-year-old, and then they're 23 and they have an optic neuritis attack. So it's something that can just come and go. We don't know why, but the good part is, again, the recovery is much better. And so that patient could have been on rituximab for 15 years, and yet, they went 15 years without an attack, and then they've had 2 attacks now with good recovery. That's why we don't tend to put patients on treatment long-term after a single attack, especially if they have good recovery.
John, thank you very, very much for helping us understand these changes in optic neuritis. I confess, at least for me, it's beginning to sink in. I seem to be able to manage the optic neuritis treatment trial back in residency, but this has been harder for my brain to tackle. So thank you very much. I did have one question about a little tidbit from back in the optic neuritis treatment trial. I recall something, and I may have this wrong, but that if you treated a patient who had white matter lesion with steroids, it had a tendency to delay the onset of MS by like a year or something, like from 2 to 3 years. And
Right.
that little tidbit, which seemed relatively trivial, still to me seemed like it had some relevance. If I was that person potentially getting MS, I'd rather live an extra year free of it. Has any of this changed that little tidbit of information? Is that still of any relevance?
That's a good question. So, if it was just, because it was just a delay by, 1 or 2 years, and then ultimately it really didn't change things. But if that could give you 1 or 2 years without MS, it could be something that you'd consider. I think now really the main question is, do you put patients on an MS medication if they've got radiologically isolated syndrome? So essentially you've got optic neuritis, you got these periventricular white matter lesions, but you haven't actually met the diagnostic criteria for MS. The debate, really biggest debate right now is not, the IV steroids to kind of extend it 1 or 2 years. Is it, do you put them on, a disease modifying agent? And really, you could ask a neurologist, a neuroimmunologist, and you would get different answers depending on who you ask. And I think that's the biggest debate right now. And there's some clinical trials out there trying to see, is that going to postpone or prevent MS for lifetime? Is this really going to help? And so that's really the raging debate right now. But again, right now you've got an attack of optic neuritis if it's severe. We tend to treat with IV steroids now just because you just don't know if one of these are going to have NMO or some of these other funny things.
Just a reminder to everybody, John has put the QR code back up on the screen for anybody who joined late. Please scan it with your phone so you can get your CME credit form easily accessible on your phone. We are pretty much out of time, well, a little over time, so it just goes to show how entertaining it was. Just a reminder to everybody, we have back-to-back visiting professors. Next week, we have Dr. Catherine Peppel speaking on multimodal imaging in uveitis. And thanks, everybody. Any closing comments from Ed or Jonathan?
Thank you.
Thanks, John, for a great talk.
Great. Thank you so much for the invitation. I had a wonderful time.
Thank you.
Take care, everyone.
Bye.
Thank you, John. Excellent. Thank you, Tom.
Wow.